Somewhere around 62 or 63, something shifts. Getting up from the couch takes a breath. Walking the driveway feels different than it did 2 summers ago. And most people chalk it up to age. They don't question it. They just adjust. Here's what nobody told them. For tens of millions of American seniors, that fatigue and weakness is not age. It is a side effect, coming from a medication they take every single day to protect their health. A pill their doctor prescribed. A pill they trust completely. 3 types of medications are behind this. The first 2 are common heart and blood pressure drugs. But the third is a medication millions of seniors take every day, and almost nobody suspects it could be contributing to weakness and fatigue. By the time this video is over, you will know exactly which ones, what they are doing inside the body, and the exact words to say at your next appointment to get a real answer, not a dismissal, not that's normal for your age. My name is Dr. Thomas. I specialize in cardiovascular health and aging. In my work with adults over 60, the pattern I keep seeing is this. The medications doing the most quiet damage are the ones sitting on the nightstand, the ones taken faithfully every morning, the ones with the most familiar names. The first medication type is statins. Statins are one of the most prescribed drugs in the United States. If you are over 60 and have any history of high cholesterol, elevated cardiovascular risk, or prior cardiac events, there is a very good chance you have been on one atorvastatin, rosuvastatin, simvastatin, one of them. They are prescribed to lower LDL cholesterol and reduce the risk of heart attacks and strokes. For many people, that benefit is real, and it is significant. But before we talk about what statins do to cholesterol, here is something most people in their 60 seconds and 70 seconds do not know, something their doctor may have mentioned once in passing, if at all. Statins block a pathway in the body that produces something called CoQ10, coenzyme Q10. You may have heard of it as a supplement, but what it actually is fuel. It is the molecule your muscle cells, including your heart muscle, use to produce energy. When that pathway gets interrupted, the muscles do not get what they need to work properly. The result has a clinical name, statin-induced myopathy. What that means in plain terms is muscle breakdown, muscle pain, muscle tenderness, and progressive physical weakness, particularly in the legs and thighs. Here is where it becomes a real problem for seniors specifically. Leg weakness that develops gradually does not announce itself. It does not come with a label that says this is your medication. It comes with a slower gait. It comes with a reluctance to take stairs. It comes with a moment at a grandkid's baseball game where you realize you don't want to climb to the top of the bleachers because your legs don't feel steady enough. And almost universally, people attribute that to aging, not to the small white pill they take with breakfast. I had a patient, Franklin, 71, retired electrician from Dayton, Ohio. Franklin had been on atorvastatin for about 6 years. He had gone from a man who spent his weekends doing yard work to a man who needed to sit down after walking from the living room to the kitchen. His previous doctor had never suggested any connection to the statin. When Franklin came to me, I ordered a creatine kinase test, a blood marker for muscle damage, and his levels were nearly 4 times the normal range. We switched him to a lower dose alternative and added CoQ10 supplementation. 6 weeks later, Franklin told me, "I thought I was just getting old." Turns out my daily routine was working against my body every single morning. Statins are not the enemy. For the right patient, the cardiovascular protection they provide is real and important. But if you are experiencing muscle weakness, leg heaviness, or unexplained fatigue, you have the right to bring it up. Here is exactly what to say at your next appointment. "I've been noticing noticeable muscle weakness, especially in my legs. Can we check my creatine kinase levels? And can we discuss whether my statin dose or type might be contributing?" That is the sentence that changes the conversation. But statins aren't the medication sending the most seniors to the emergency room every year. That belongs to this next category, and the side effect has a name most people have never heard. You are finding this useful. If any of what you've heard in the last few minutes has made you think differently about a medication you or someone you love is taking, hit subscribe right now. Next week, I am covering the one blood test that most seniors over 65 are never given, but that predicts physical decline 5 to 10 years before symptoms appear. Your doctor is probably not ordering it. You are going to want to know what it is before your next annual physical. The second medication type is blood pressure medications, specifically when the dose is too aggressive. High blood pressure in older adults is one of the most monitored conditions in American medicine. Beta blockers, diuretics, ACE inhibitors, these are in the top 10 most prescribed medications for adults over 60. And for good reason. Uncontrolled hypertension is a serious risk. Nobody is disputing that. But here's what the system often gets wrong. The push to get blood pressure numbers down can become so aggressive that the numbers drop further and faster than the aging cardiovascular system can handle. And the specific consequence of that, the one that sends thousands of American seniors to the emergency room every year, has a name most people have never heard: orthostatic hypotension. Orthostatic hypotension means this: when you stand up from sitting or lying down, your blood pressure drops suddenly instead of adjusting smoothly. For a younger cardiovascular system, that adjustment happens in seconds. The vessels compensate, the pressure stabilizes, you stand up normally. After 60, that compensation mechanism is slower. Add a blood pressure medication that is actively forcing pressure down, and what you get is a sudden rush of dizziness, a graying of the vision, a wave of weakness that hits the moment you're vertical, and it passes, but it passes slowly, and in that window you are unstable. This is not a minor annoyance. In the United States, falls are the leading cause of injury-related death in adults over 65. And orthostatic hypotension, this exact side effect is one of the most consistently identified contributors to those falls. Hip fractures that result from a fall in a senior 70 or older carry a sobering statistic. A significant percentage of those patients do not return to their prior level of independence, ever. The weakness here is not the kind that builds over months. It is the kind that arrives in the 3 seconds it takes to stand up from the dinner table. It lasts 30 to 60 seconds. And because it is brief, most seniors never think to mention it to their doctor. They think, "I just stood up too fast." They sit back down. They wait for it to pass. They do not connect it to the blood pressure pill. I want to tell you about Margaret. She was 68, a retired school teacher from Tucson. Margaret had been put on a combination of a beta blocker and a diuretic about 14 months before she came to see me. Her numbers looked good on paper, but Margaret had started holding on to walls. She had quietly rearranged her living room so there was always something within reach. When I asked her to check her blood pressure sitting and then standing, her systolic pressure dropped 28 points in under 30 seconds. She looked at me and said, "That's why I feel like I'm going to fall. That's the feeling." We adjusted her dosage. 3 weeks later, she called and said she had walked to her mailbox and back without touching anything. Here is the sentence for your next appointment. "My blood pressure seems to drop when I stand up. I feel dizzy or weak for a few seconds after standing. Can we measure my blood pressure sitting and standing and check whether my dosage needs to be adjusted?" Your doctor can run this test in 5 minutes. You do not have to keep holding on to walls. And now we get to the third medication, the one that catches people the most off guard, because it has nothing to do with your heart or your circulation. Most people take it for something they consider a minor annoyance, and it may be quietly draining the nutrients that keep your muscles and your energy functioning. Have you noticed any of what we've talked about so far? The leg heaviness, the stand-up dizziness, the unexplained fatigue? Is any of this something you've been living with and just accepting? Drop a yes or no in the comments. I read them, and if you've already talked to your doctor about this and gotten a real answer, tell me what they said, because that kind of experience helps everybody watching. The third medication type is proton pump inhibitors, PPIs. When you think about what makes you weak, you think about your heart, your muscles, your circulation. You do not think about your heartburn pill. But here is what is happening in the bodies of millions of American seniors who take a PPI, omeprazole, pantoprazole, esomeprazole, the ones sold under names like Prilosec and Nexium, every single day for years. And it starts with understanding what these drugs actually do. PPIs are designed to reduce stomach acid. That is their job. They do it effectively. For someone dealing with chronic acid reflux or GERD, they bring real relief. But stomach acid is not just an irritant. Stomach acid is how the body breaks down and absorbs certain critical nutrients, specifically magnesium, calcium, and vitamin B12. When stomach acid is suppressed long-term, those nutrients stop being absorbed properly. Not all at once, slowly, over months, over years. The body draws down its reserves, and those reserves quietly run out. And what do low magnesium, low B12, and poor calcium absorption look like in a person over 60? Chronic fatigue that no amount of sleep fixes, muscle cramps, particularly at night, a kind of neurological weakness, a heaviness in the limbs, a mental fog, a difficulty concentrating that does not respond to rest, and over time, bone density loss that does not show up in how a person feels, but shows up dramatically in how they fracture. The reason this is so easy to miss is that PPIs are often prescribed once and never revisited. A doctor gives them to manage a problem, the problem gets managed, and the prescription just continues, month after month, year after year, with no conversation about when to stop. and no monitoring of what the long-term suppression is doing to nutrient levels. I worked with a woman named Dolores, 73, retired accountant from Fort Worth, Texas. Dolores had been on pantoprazole for almost 7 years. She had become what she called permanently exhausted, sleeping 9 hours and waking up tired, getting leg cramps at 2 a.m., and her daughter had noticed she seemed slower in conversation. 3 different doctors had run standard blood panels. Nobody had run a B12 or magnesium level. When I finally did, her B12 was critically low, and her magnesium was in the basement. We began a supervised step down from the PPI and started targeted supplementation. 4 months later, Dolores told me, "I forgot what it felt like to wake up and feel like a person. I thought that was just gone." It was not gone. It was being blocked by a pill she took every morning for heartburn. Here's what to say. "I've been on this reflux medication for a long time. Can we run a B12 and magnesium panel? And can we talk about whether a step-down plan makes sense for me at this point?" That is a reasonable, medically appropriate request. A good physician will take it seriously. Now, here is what to do with all of this. Not tomorrow, not at the next appointment that might be 3 months away. Today, start a simple log. On your phone, on a notepad from the kitchen drawer, anywhere. Write down every medication you currently take. Next to each one, write one sentence about how you feel on a typical day. Legs heavy, energy low by noon, dizzy when you stand. That log is your first piece of evidence. It turns a vague feeling into a documented pattern. And a documented pattern is something a doctor has to engage with. By day 7 of keeping that log, you will start to notice correlations you had been missing. By day 14, you may have enough information to walk into an appointment and say with confidence, "This is what I am experiencing, and I want to know if my medications are contributing." By 30 days, you will have a record that any physician who takes you seriously will find useful. The challenge is this. For the next 30 days, track how you feel. Every morning. 2 sentences. What your legs feel like. What your energy level is. Whether you felt dizzy when you stood up. At the end of 30 days, bring that log to your doctor. Do not summarize it. Do not downplay it. Just hand it over and say, "I've been keeping track." Those 4 words change the entire dynamic of a medical appointment.